Welcome to the Explainer. Today, we're diving into a microbe that pretty much breaks all the rules, Neisseria elongata. Think about it. It's a rod in a family of cocci. It's a harmless bug that lives in your throat that can suddenly cause devastating heart infections, and it's a hidden reservoir for antibiotic resistance. We've pulled all this together from a Gemini deep search, and hey, if you want to see all the sources, they're right there for you in the linked notebook.
So let's just kick things off with a question that kind of messes with a core concept in microbiology, right? What if Neisseria wasn't a coccus? This question, it gets right to the heart of why Neisseria elongata is so fascinating, and frankly, why it can be such a troublemaker in the lab. It completely challenges a fundamental trait we associate with the whole genus.
And right there, that's a central paradox. You've got this organism that is a rod in a family that's supposed to be cocci. It's a totally normal resident of our throats that can, out of nowhere, cause these absolutely destructive heart infections. And while it's just sitting there quietly, it's secretly picking up and sharing antibiotic resistance genes with some of the scariest pathogens we deal with. It's this complex, multifaceted identity that makes it so critical for us to understand. Okay, so here's how we're going to break this down. First, we'll look at its atypical identity. Then we'll jump into its lab profile and its role as a reservoir for antimicrobial resistance. From there, we'll dig into the very real clinical threat of endocarditis, tackle the big challenges in treatment, and finally wrap up with how modern diagnostics and prevention are changing the game. All right, let's jump right into Section 1, an atypical Neisseria. We're going to get into its taxonomy and talk about why its very shape can create a diagnostic puzzle right from the get-go.
So the formal definition is crystal clear. It's a Neisseria. But that species name, elongata, well, that's the big giveaway, isn't it? What's really interesting is that phylogenetically, it's the most ancestral human Neisseria, which gives us this cool glimpse into the genus's evolution. But practically speaking, when you see a gram-negative rod under the scope, your brain doesn't immediately scream Neisseria, and that can lead to some really critical delays in identification.
Okay, moving into Section 2, let's head over to the lab bench. We're going to cover the key ID tests and, just as importantly, explore why this seemingly harmless commensal plays such a huge role in the global crisis of antimicrobial resistance. So for the microbiologist at the bench, the picture starts to come together piece by piece. You see a gram-negative rod, though sometimes it can look gram-variable, which just adds to the confusion. It grows nicely on blood and chocolate agar, but it won't touch selective media like McConkey or modified Thayer-Martin. But the real clincher, the absolute key, is that positive oxidase test. That whole combination, that's the classic signature of Neisseria elongata. But, it gets even more granular than that. The species is actually split into 3 subspecies, and telling them apart is clinically super important. Why? Because the nitroreducens subspecies is the one we see most often in serious diseases like endocarditis. This table shows the simple biochemical tests that sort them out. And notice the catalase reaction. Subspecies elongata and nitroreducens are catalase-negative. That's another feature that's pretty atypical for the major pathogenic Neisseria and can totally throw you off the trail. Now, this is where the public health significance of Neisseria elongata just explodes. It goes way beyond the rare infections it causes. See, the whole Neisseria genus is naturally competent, which is a fancy way of saying it just loves to pick up DNA from its environment. So Neisseria elongata is just hanging out in the throat, acquiring resistance, and it's become the original source of the mosaic penne alleles that have made Neisseria gonorrhea such a nightmare to treat. It's a silent but incredibly important reservoir for resistance. Okay, Section 3. Let's pivot now from the lab to the patient. How in the world does this harmless commensal become such an aggressive pathogen? We're going to focus on its most feared clinical presentation, infective endocarditis. I'll tell you what, when Neisseria elongata decides to cause endocarditis, it does not mess around. We're talking about an acute, really destructive process. The bacteria form these large, fragile vegetations on the heart valves, and it's usually on the left side, the aortic and mitral valves. The pathway in is classic. It gets into the bloodstream from the mouth, maybe after a dental procedure or in someone with poor oral hygiene, and it finds a home on a heart that already has some underlying structural damage. This number right here, this really hammers home how severe this disease is. Between 50 and 60% of patients, that's more than half, will end up needing surgical valve replacement. This is not an infection that's easily managed with just antibiotics. The structural damage to the heart is often just too severe.
And if you're wondering why surgery is needed so often, well, just look at these devastating complications. The infection can cause congestive heart failure from leaky valves. It can actually burrow into the heart tissue, forming a perivalvular abscess in up to a third of patients. And worse, pieces of those big, fragile vegetations can break off, travel to the brain, and cause a stroke, or go to other organs. It's a truly life-threatening infection.
So this brings us to section 4, and honestly, a major clinical headache. Treating these severe infections is tough because we're often flying blind, operating in this gray area without specific, evidence-based guidelines or standardized susceptibility breakpoints to guide us.
This slide just lays out the treatment conundrum perfectly. On one hand, you have international guidelines, like the American Heart Association's. They extrapolate from the slow-growing HACCP group and recommend a 4 to 6 week course of ceftriaxone, and they explicitly say do not add gentamicin. But then you go and read the case reports in the literature, and you find that doctors often do add gentamicin, hoping for a synergistic effect. And then you've got national guidelines, like the Dutch swab guidelines, which have no specific recommendation at all, leaving clinicians to figure it out case by case.
And the situation is even more uncertain in kids. This infection is incredibly rare in children, and when we do see it, it's typically in those with congenital heart disease. With zero pediatric-specific guidelines, specialists have to extrapolate from adult protocols, for example, using a weight-based dose of ceftriaxone at 50 milligrams per kilogram per day.
And all of this brings us to the core problem for the microbiology lab. You run the susceptibility test, you get a number, the MIC, but what on earth does it mean? Without official clinical breakpoints from a body like UCAST, you can't just slap a susceptible or resistant on the report. This is a huge interpretive challenge.
So what's the solution? Well, the recommended practice, guided by the European Committee on Antimicrobial Susceptibility Testing, or UCAST, is to report the raw MIC value and then add a critical interpretive comment, just like this one. You compare the result to breakpoints for related organisms. So here, an MIC of 0.19 milligrams per liter for ceftriaxone is above the breakpoint for other Neisseria species. This simple comment turns a number into a clinical alert, and it forces an absolutely essential conversation with the infectious disease team.
All right, finally, section 5. Let's look at how technology has really sliced through all that diagnostic confusion and how we can use some practical measures to stop these dangerous infections from ever happening in the first place. You know, the story of Neisseria elongata's emergence isn't about the bacterium changing. It's about our ability to finally see it. In the past, its weird gram stain and rod shape meant it was often missed or just written off as a contaminant. But now, with MALDI-TOF mass spectrometry, we can get a rapid, accurate ID, sometimes in a matter of hours. And for the really tough cases, 16S rRNA sequencing gives us the definitive gold standard answer. This tech has completely transformed our understanding of how often this pathogen is actually causing disease.
So how do we prevent it? Well, for a patient in the hospital who has an infection, simple, standard precautions are all you need. It's not transmitted from person to person like Neisseria meningitis. The real prevention happens outside the hospital. The absolute cornerstone is just good oral hygiene to reduce the amount of bacteria in the mouth. And for high-risk patients, those with prosthetic heart valves, following the guidelines for antibiotic prophylaxis before certain dental procedures is absolutely critical.
So the key takeaway here is this. Neisseria elongata is not a microbiological curiosity anymore. It's a rare but clinically significant pathogen. Managing it effectively demands a high index of suspicion from clinicians, it needs rapid and accurate identification from the lab, and it requires tight collaboration between microbiologists, infectious disease physicians, and cardiothoracic surgeons. And we'll leave you with this final, kind of provocative thought. Given its role as this major resistance reservoir, could actively monitoring the susceptibility of commensal Neisseria elongata act as an early warning system for the next wave of resistance in Neisseria gonorrhea? It's a really fascinating public health question. If you found this explainer useful, please subscribe to our channel and definitely let us know your thoughts in the comments below. We'd love to hear from you.